primary objective of this paper was to determine whether two DXA-based estimates of adiposity, including percent trunk fat and percent body fat, improved risk prediction for cardiometabolic diseases and all-cause mortality compared to two traditional clinical measures, body mass index and waist-hip ratio, in older women. My name is Deepika Laddu. I'm an assistant professor in the Department of Physical Therapy at the University of Illinois at Chicago. And today I'm going to present on our results from a study entitled DXA versus Clinical Measures of Adiposity as Predictors of Cardiometabolic Diseases and All-Cause Mortality in Postmenopausal Women. This manuscript will be presented in the November 2021 issue of Mayo Clinic Proceedings. In these analyses, we included data from nearly 10,000 postmenopausal women who are participating in the Women's Health Initiative. These women were aged 50 to 79 years at enrollment and underwent a DXA scan and also had complete information on BMI and waist-hip ratio. In addition, these women were free of cardiovascular disease and diabetes at baseline. Using this data, we evaluated in separate multivariable models the risk of incident diabetes, atherosclerosis-related cardiovascular diseases, which we further discriminated as broad versus hard atherosclerosis-related cardiovascular disease, heart failure, and death due to all causes. We then compared the relative discriminatory value between the pairs of adiposity measures. Now, overall, the most striking findings of this study showed that percent trunk fat demonstrated the greatest magnitude of association for incident diabetes, and to a lesser but statistically significant extent, broadly defined atherosclerosis-related cardiovascular diseases. This was compared to all other adiposity measures. In addition, this finding was also accompanied by substantial and significant improvement in risk prediction of diabetes and atherosclerosis-related cardiovascular diseases over percent body fat, BMI, and waist-hip ratio. Importantly, the improvement in discrimination was observed independent of all relevant clinical risk factors, including BMI. Likewise, percent trunk fat consistently demonstrated the largest hazard risk across all ages observed for diabetes and atherosclerosis-related cardiovascular disease outcomes. It's important to note that these findings may be a consequence of changes in body composition that occur in women during and following completion of menopause. The changes in body composition during this period typically are characterized by a distribution of fat with increases in both subcutaneous adiposity and visceral adipose tissue, which confers more of a pathogenic nature. We also know that with increasing age, abdominal visceral fat tends to accumulate in women without appreciable changes in waist circumference, body weight, or BMI. And this may further limit the predictive utility of these traditional clinical surrogates in terms of predicting future disease. Other factors that were not accounted for but should be considered when interpreting these findings are that changes in adiposity or lean body mass resulting from age-related comorbidities such as cancer or depression, or from temporal changes in lifestyle such as diet and physical activity may also promote clinical or subclinical cachexia or sarcopenia, which in turn influences changes in body composition during aging. The implications of these findings suggest the incremental value of percent trunk fat derived by DXA overall corroborate with previous studies that have emphasized the clinical value of measuring abdominal fat using other imaging tools, such as CT or MRI. However, with these latter technologies, while they do have the direct advantage of distinguishing visceral fat, which is again the more pathogenic fat depot that we are targeting using percent trunk fat, these devices are associated with high radiation exposure, which is generally the case for CT, or have high cost or burden to the healthcare system. And both CT or MRI usually require a follow-up on incidental findings. In contrast, a DXA scan offers nearly the same information as CT or MRI in terms of measuring adiposity. It's also lower in cost and it incurs trivial exposure to radiation. Now, more relevant to these findings, however, is that DXA scans are recommended to all women aged 65 years and older in order to assess the risk of osteoporosis. Now, again, this age coincides with well-documented literature suggesting that traditional surrogate markers, such as BMI or waist-hip ratio, may be less predictive in discriminating risk of cardiometabolic diseases. To conclude, these findings highlight the need for additional observational or intervention studies that will confirm the incremental utility of DXA, and also include known biomarkers for diabetes and atherosclerosis-related cardiovascular diseases. Now, future studies would help us understand further the impact of abdominal adiposity in the development of cardiometabolic disease, and would also help us to refine screening recommendations for the primary prevention of diabetes and cardiovascular disease in older women. Thank you again for listening to the summary of our manuscript results, and I encourage you to read the full manuscript in the November 2021 issue of Mayo Clinic Proceedings.
We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.